morning, I'm John Kanellopoulos, and I'm very pleased to present to you the use of the Artisan Aphakia lens, retropupillary, in complex anterior segment cases. These are my financial interests, and I've been working with the Artisan lens for almost 20 years now. We have reported in 2004 its use, this is in the Journal of Cornea, its use in combination with penetrating keroplasty, and at the time we reported its use in its traditional fashion, enclavated in front of the iris. So within the anterior chamber, in front of the iris, and as a means to eradicate problems with angle fixated anterior chamber intraocular lenses with relatively good results. But things have changed since then, and I'm going to show you some examples of surgery. These are from meetings we've presented. This is a typical case with an anterior chamber, Kelman-like angle-supported intraocular lens. Obviously, the angle from the surgery and from the lens has developed significant glaucoma, so we are planning here to not only exchange this lens that you can see is decentered and thankfully has not decompensated the cornea yet, so I prefer to do this with a sclera incision, not a clear cornea incision. Thus, all the bleeding you see here and the preparation of the sclera. Let me go back to that point, and I inadvertently. So go here, create a sclera tunnel of 6 millimeters width. You can see here my incision also includes a significant part of a clear cornea incision. So it includes a 2 to 3 millimeter sclera, limbus, and 2 millimeter clear cornea incision. And this incision is watertight. So we're going to go here and remove the lens. When the lens is removed so easily after years of implantation, as a cornea surgeon, I know there's significant cornea damage because that means the lens is vibrating in the eye. Going in with viscoelastic, I first check to see if there's any vitreous left. If there were, I will perform a generous anterior vitrectomy. So very carefully here, so the manipulations of inserting the Artisan lens would not further damage the cornea. So I purposely here with my right hand grasp the lens not in the middle but obliquely, so I can place the initial haptic in and then enclavate the initial haptic, and then gently come and grab the lens and curl the iris around it. The lens is obviously placed upside down to make sure that the curve of the lens does not make it rub with the iris. Prophylactically, I'm putting in a few sutures, although most of these incisions are watertight, and one of the reasons is that I'm going to go on in this case and finish with a AMID glaucoma valve. So filling here the chamber, myocule, closing as carefully as I can. Sometimes the wound requires more sutures because of the cautery, constricts the collagen, and thus finishing here the incision and then going on to add a AMID valve here. Placement through the sclera and the anterior chamber, and then a sclera patch. And I'll show you the post-ops. Early post-op here, and this is the same eye quite a length later. So you can see one of the advantages in placing the lens retropupillary is that you have a relatively deep chamber. It's very easy. The lens implantation took almost 2 minutes. I know there's other options out there, such as glued IOL for these challenging aphakia cases, that there's no capsule support. But in my hands, that's a far more complicated and time-consuming procedure. And a lot of people are concerned that the lens enclavation would create iris problems, but actually the iris is very good in supporting these lenses. You can see here where the lens is enclaved. Actually, this is the tube in the anterior chamber, and we're going to go on and see the enclavation, first enclavation point. You can see it here, and this is an area of the iris that normally doesn't move much in dilation and constriction, and we'll see the other point of enclavation there. So this is a cataract PK penetrating keratoplasty in a patient with Axenfeld-Rieger syndrome. This is quite a rare, complicated case. So we'll go and see the pathology. The problem here is that the iris has a lot of synechia with the cornea. So the cornea has decompensated. You can see how edematous the cornea is. So we're going to go in, do a penetrating keratoplasty and open sky cataract surgery. And during this procedure, I want to make sure that I can implant the lens as soon as possible. I'm going to go in and do an open sky vitrectomy, and here, open sky, and this is where time matters to me. I want to finish this procedure as soon as possible. Implant the Artisan lens again by enclaving both haptics. This is a good example to show you that even in iris that has atrophy, you can see the significant deficits of the iris in Rieger's Axenfeld syndrome. You're able to enclave the lens, get a pretty stable position, and then do a iridectomy and finish the procedure with a cornea transplant. This is a plain aphakia case, and similar procedure, a conjunctival peritomy, cautery, and then I like to do a scleral tunnel. You see again, my tunnel is about 2 to 3 millimeters in sclera, and then proceeds into clear cornea. And you can see again here the incision where the clear cornea part of the incision is at least 2 millimeters. So this is almost a 4 millimeter width within the sclera and cornea incision. Again, prepare the patient. I'm going to use viscoelastic, take the Artisan Aphakia lens, flip it over. You can see here, this is how the lens comes out of the set. Maybe Ophthec can preload these lenses already upside down, so we don't have to do this intraoperatively. The ones that are meant to be placed retropupillary. And then flipping the lens upside down, coming in, and in similar fashion, putting in first the first haptic, enclaving the first haptic. Here I'm enclaving the first haptic using my left hand and my right hand for the enclavation, and then going on to the other haptic to enclave the other haptic, as you can see here, using my right dominant hand to hold the lens and my left non-dominant hand to enclave the lens. So it's relatively straightforward procedure. In my initial cases, I would mark, according to the orientation of the lens, on the limbus, 2 marks in order to make sure that I'm in the central of the eye. But I really don't do that anymore. Just by habit and experience, I can place the lens relatively centered. And again, you can see this case. We're done with an IOL implantation, a patient with no capsular support, in essence, within under 10 minutes. So a very simple procedure. This is a similar case with the one I showed you before in a pediatric aphakic patient who also has significant glaucoma. So this was a patient who had cataract surgery when he was 9 months old, and we're seeing him now at 15 with significant glaucoma. And I felt that the glaucoma was also related to vitreous present in the anterior chamber. So the aphakia correction is not only meant to be a refractive procedure here, but also a means to reduce the communication of the posterior chamber with the anterior chamber. So besides going in, again, same fashion, scleral cornea incision, you'll see me placing here some Kanellopoulos. I'm searching to see if there's significant capsular support here. Maybe I can put a posterior chamber intraocular lens in the angle. There is some capsular support, as you can see there, some remnants, but there's no capsular support in the rest of the eye. So I'm going to use some Kanellopoulos to color the vitreous, and you can see there's vitreous even in the anterior chamber. Perform a careful anterior vitrectomy and go into posterior chamber, and this is the part where, again, I'll take the Aphakia Artisan lens, flip it over, and come in and enclave the lens. Relatively simple procedure. Again, I'm going in with my dominant eye my right hand holding the lens obliquely sideways, and then using my non-dominant hand here to enclave the first haptic first, and then switch hands, grasp the lens, tuck the iris around it, and enclave the other haptic, and then go on with the tube in this aphakia glaucoma pediatric patient. And I'll show you in a few seconds. We were able to control the intraocular pressure and we're able to offer this patient significant visual rehabilitation to his anisometropia, because he was plus 12 in one eye and plan on the other eye, and now he's functioning with about 20/50 vision in this eye and well-controlled intraocular pressure. I think I have one last case for you. This is a case where, from the title, you understand that the anterior chamber intraocular lens had caused cornea decompensation. So we're going to do combined a IOL exchange with an Artisan lens and a dissect procedure. And I'm going to use, the novelty here is I'm going to use the femtosecond laser to create the dissect incisions and the incisions, clear cornea incisions for the Artisan lens. And we're going to close this procedure not with sutures but with glue. So again, removing the intraocular lens. This is not an anterior chamber intraocular lens, this is a posterior chamber intraocular lens. So the bullous keratopathy is probably from vigorous maneuvers during the procedure. So I'm fishing out this lens. I can tell from the capsule that this was probably a pseudoexfoliation patient. There's a lot of white material within the capsular bag, so thus the laborious phaco. So the lens comes out with a bag, so I have no support to put a lens in. I'm again performing a careful anterior vitrectomy by using Kanellopoulos to color the vitreous, taking my Artisan Aphakia lens, flipping it over, and then coming in to clip the lens here, the initial haptic, and then the trailing haptic. And following that, the dissect procedure, iridectomy. Because I'm doing dissect, I do two iridectomies, one inferior, one superior. With plainly the Artisan lens, I would only use just one iridectomy. Now I'm scoring the Decimet's membrane, pulling Decimet's, and then with a Busin inserter, I'll draw in the dissect graft. I'm using glue here instead of a suture, so this is sutureless Artisan dissect procedure, and this is the case several months later. You can see the lens centration, it's excellent. The dissect graft is really giving corneal clarity, very good result. And one last case here. Tell me when you're tired of watching videos, because I have a few. This is a sunset case. You can see the IOL margin a little bit under the middle of the pupillary aperture. Again, just by looking at the capsule and the white material, although I saw this patient for the first time like this, I know that this is a patient who had pseudoexfoliation, was a difficult cataract surgery. Probably there was capsular rent during the procedure, and the three-piece IOL that was placed found the hole and sank within the capsular bag. So again, similar technique, scleral incision. I'm going to fish out the IOL. So you can see the IOL is coming in with the capsular bag. See the white material on the IOL, that's the anterior part of the capsular bag, which is coming out with the lens. You can see it here. So this is a typical pseudoexfoliation patient, very, very common in Greece, very common in Scandinavian countries, very common in Jewish population. The Russian Jewish population that I took care in Brooklyn when I ran the university there had a significant number of pseudoexfoliation patients. So again, here's the lens, flip it upside down in order to have its curved side sit under the iris, and then enclave the lens. Use Kanellopoulos to make sure I have no vitreous in the anterior chamber. Tuck the conjunctiva, and again, this is a result postoperatively, patient 2020. We obviously have used the Ophthec A constant which is different than if you put the lens in front of the iris when you're placing it behind the iris. Very good result for long term. And you can see the enclavation points where the iris is enclaved. You can see on the left side that the actual haptic has gone through the iris, which I particularly like because I can see the haptic going through the iris in the anterior chamber, and that secures for me that the lens by no means is ever going to fall back. Okay, and I think this is the last case. So this is a case where we again are going to remove a anterior chamber intraocular lens, use Kanellopoulos for vitrectomy, and place a Artisan lens, and finish with a dissect procedure in this patient that had compensated cornea. You can see this case a week later. There's two sutures in the cornea from the dissect surgery, and you can see the Artisan lens in perfect position, perfect pupillary opening, and the enclavation point here, the dissect graft here. And this is again another femto Artisan Dissect case. So in summary, in my hands, retropupillary fixation of the Artisan lens has been an excellent alternative to other treatments for aphakia, such as sutured IOLs or glued IOLs. I particularly like it because not only is it very fast, and when it's combined with keratoplasty procedures, I like the quickness of the procedure, but also I feel that the enclavation of the lens on the iris gives a very stable result long term. I've also used this enclavation to, along with the enclavation, perform a iridoplasty. Sometimes when the iris is irregular, I will use the enclavation as a means to shape up the iris, and I think that in my hands, it offers a significant advantage to placing any anterior chamber intraocular lens, and as far as speed and stability of the result, a much more facile procedure compared to suturing an IOL or gluing an IOL. Thanks very much for your attention, and thanks for inviting me.
Question.